Good morning, all. This is Dr. Shweta Santhalia, the course director and mentor at MRCOG. Today, I'm here to discuss with you all the new, not new actually, but very important guideline of infection in pregnancy, because infection in pregnancy is very important aspect of exam, part 2 exam, and always there are many questions from that as well as the EMQs. So we have to be really thorough with the infection in pregnancy. This is 2017 guideline, prevention of early onset neonatal group B streptococcal disease, famously known as
The EOGBS, prevention of early onset neonatal group B streptococcal disease. This is September 2017 guideline. Very important. Always there is a question from this guideline because this is sometimes become confusing. That's why this is their favorite and they keep asking this. As well as they don't do routine screening for GBS. That's why they want you to know how to give prophylaxis to avoid the baby getting exposure and infection. So this is the main crux of this guideline, how to avoid the infection to the baby. So antenatal screening, if you see, group B beta hemolytic streptococcus, also known as GBS, also known as Streptococcus agalactiae. This is important to remember the other name of this infection because sometimes you will get confused. GBS you always remember, but sometimes you don't know this other name and they will give you an option Streptococcus agalactiae. So you should remember that the synonym of GBS is agalactiae. Can I ask you what is the synonym of gas? GAS. Group A hemolytic streptococcus. Because that is important from sepsis point of view. We will see in the next session of postpartum the uh, sepsis in the mother and postpartum period. Gas is very important. So what is the other name for
Streptococcus
gas?
or
Pardon?
pyogenes.
Pyogenes. Yes, very good. So remember that is Streptococcus pyogenes and this is GBS or Streptococcus agalactiae. So very important. Now, this is the most frequent cause of severe early onset infection in newborn. Within 7 days, whenever a newborn gets severe infection, this is the most common cause. That's why they're worried. That's why they say that we shouldn't have the baby with this. That's why you are giving the prophylaxis. Okay. If you see the colonization in the bowel flora, it is found in 20 to 40% of the adult. So this is important that routinely it is found in bowel flora in 20 to 40% of the adult. Intrapartum IAP is intrapartum antibiotic prophylaxis. We'll keep seeing about IAP short form further. So I've just written it here. Intrapartum antibiotic prophylaxis will reduce early onset infection, means within 7 days. But it is not going to reduce the late onset, means after 7 days you cannot avoid by this prophylaxis. So be clear about that because it is not going to avoid the late onset infection. Late onset the baby can get, but late onset is not that dangerous. So you want to avoid the early onset because that is most dangerous for the baby and even the baby can die if you don't treat or prevent it. So that is what this whole meaning of this guideline that you want to avoid the infection in the baby because it is dangerous for the baby. Now, they don't recommend universal screening. So if they are so much worried, why they have not recommended universal screening? They don't recommend it because there are flaws of screening. Because screening is not 100% accurate. And for preterm, anyways, your timing of screening is 35 to 37 weeks. So preterm delivery, you cannot detect. So these are some flaws. That's why they say that universal screening is not recommended. That's why they don't do it. So they say that many women will carry the bacteria, but the baby will be born safely. Means the transmission to the baby or infection to the baby is not 100%. Obviously, any infection is not 100% transmissible or affecting. So they say that many women, even if they are having no harm to the baby, then why should we screen? If you are screening late in pregnancy, you cannot predict the preterm. So what is the benefit? If you are doing the screening, 17 to 25% of the women, though they are having positive swab when you are screening, but negative at the time of delivery. So you screened, you got it positive, you took all the precaution at the end. Up till 1 in 4, they were not having it at delivery. So you have unnecessarily done all the infection. 5 to 7% they say that even if it come negative at the your documented time but later it will become positive, so screening is not 100% accurate because 5 to 7% it is false negative at 35 to 37 weeks. So that's why they say that it is not accurate and they don't want to do it for everybody, but they will make a protocol how to avoid it and make the baby safe. For premature, definitely you cannot detect by doing 35 to 37 weeks. If you are giving to all the carrier, you are giving intrapartum antibiotic prophylaxis, then it will be a very large number of women who are going to receive the treatment, and which is not that cost benefit. So that's why they say that they will not screen for it but prevent it by giving the antibiotic to the suitable women. So what are the risk factors? What are the risk factors for the women to have the transmission of the infection to the baby and baby getting affected? So if they have previous baby with GBS disease, this is very important. If they have previous baby with GBS disease, irrespective of whatever her status is this time, you are going to give her prophylaxis. So previous baby with GBS disease, please don't forget. This is a favorite question. Previous baby had GBS disease, so this time you are going to give prophylaxis irrespective of her status. Plus, in spite of giving prophylaxis, you are going to monitor the baby for first 12 hours. So this is the unique scenario where you don't have to document her carrier status but give her prophylaxis as well as monitor the baby. Now, if the mother is carrier, if you incidentally find it, sometimes you are taking vaginal swab for some other infection and you saw that GBS infection is there. So if the mother is carrier, urine or vaginal swab, or if you get urine, you have done urine culture and you find GBS, in that case, the mother is carrier, you know. So if the mother is carrier, then all the problems start. If the mother is carrier, you want to give her during labor, during delivery, during preterm, during PPRM and all that things. So mother carrier, if you know the status, definitely that is a risk factor for the baby and you will give the prophylaxis. If preterm birth, irrespective of her status, you are going to give. Very important because preterm birth is before 37 weeks. So you have anyways not tested her. So they have made the protocol that for all preterm you are going to give them the prophylaxis. But here is a catch. You will give only to confirm preterm, not the threatened preterm. So please be careful about that. Confirm preterm means after 30 weeks only you will do the ultrasound and the testing for this fetal fibronectin FFN testing. So if you do that, then only you can confirm that it is preterm birth. So if it is a confirmed preterm, then only you will give the prophylaxis, not for the threatened preterm. For PPROM, you will give because for preterm you are giving. So definitely if PPROM, you are going to give. If suspected maternal intrapartum infection means intrapartum pyrexia, the risk become 10 times. That's why the transmission risk become 10 times. So intrapartum infection, irrespective of her status, you are going to give. Intrapartum pyrexia whenever they have, that's why they made the recommendation that you will give a broad spectrum antibiotic which should cover the GBS infection also. So intrapartum infection, intrapartum pyrexia, preterm PPRM, these three you are going to give her irrespective of her status, even if she is carrier or she is not a carrier. You don't need to test for them. You are going to give them. So this is what you have to remember. These are the obligate things where you are going to give previous baby with GBS, you are going to give plus baby monitoring. And if she's a carrier, definitely you want to give. So this is what you have to remember. Now, if you see how much is the risk, this is very important because sometimes they simply ask you how much is the risk to the baby. So generalized risk, if you see, it is 0.57 per thousand to the baby. Or if you see 0.57, so if 7 is more than 5, so you will take it one more. So or 0.6. What is why I have mentioned it specifically because previous guideline they have mentioned 0.5 and in the new guideline it is zero point 0.6. So if you get a question how much is the incidence, you will choose 0.6. You will never choose 0.5. So be careful about that. It is 0.57 per thousand. So if they don't give you so much decimal, you will choose zero point 0.6 per thousand. Very specific and be very clear about that. So this is the general incidence. If anybody, uh, uh, even if you test or not test, it is the general prevalence of the GBS in the baby. Now, if it is preterm, the risk will increase further because we know preterms are more at risk. That's why you are giving irrespective of the status. So preterm is more at risk. So how much more at risk? Approximately four times of this. So 2.3 per thousand. Very important. If she develop pyrexia, intrapartum pyrexia, it becomes 10 times, right? From zero point 0.5, it has become 5.3. So almost 10 times it has increased. So preterm and pyrexia is something you are irrespective of the status you are going to treat them with the prophylaxis. Now, the other challenging thing is previous GBS. If she was previous GBS carrier, and supposedly you have given her the prophylaxis in previous pregnancy, now this pregnancy what to do? This is the other aspect. If she has previous GBS in previous pregnancy, this time she having the GBS is 50%, 50% chance. So definitely this time the risk to the baby will be more. So it is 1 in 700 to 800, means approximately 1.2 times. So it is zero point 0.6 in place of zero point 0.6, 1.2. So almost 2 times. So this is almost 4 times, 10 times, and this is 2 times. So if the risk is higher because of the previous GBS carrier, definitely you can offer her the testing or you can offer her directly the IAP. This is the catch. They will give you she's previous GBS and now she's refusing the testing. What you will do? If she's refusing the testing, 50% there is a chance that she might be carrying, so you will directly give her prophylaxis. Or if she'll agree for testing, you will do the testing and accordingly you will manage. So you did the testing, you found it positive, the risk will be further higher, so it will be 2.5 per thousand. And if you found it negative, the risk will be same as background risk, low risk because you have found somebody negative. This is when you are not knowing the status. Here you are knowing that the mother is GBS negative. In that case, the risk will be zero point 0.2 only. The same asymptomatic term infant without risk factor, the risk is only zero point 0.2. So please remember all this percentage, all these numbers, because this is sometimes a favorite and they ask you how much will be the risk. If you see in preterm, even transmission is more, even mortality is 10 times. So preterm and pyrexia, two P's, you are really worried. And the third P is previous GBS, where all this confusion arise and where the outcome, what the testing will come. If it is positive, it is again like preterm, quite high. So these are the P's you are worried for in cases of EOGBS. Am I clear about this slide? Have I made it easier for you to remember?
Yes.
So if GBS has detected in previous pregnancy, as I told you that the likelihood of this having in this pregnancy is 50%. So either you will directly offer the prophylaxis or she can choose the testing. Testing, you all know that you are doing at 35 to 37 weeks. So it is 3 to 5 weeks prior to the anticipated delivery date because delivery will be from 40 to 41 weeks. So they 40 to 42 weeks. So they are choosing 35 to 37 weeks, 3 to 5 weeks prior, right? So if it is a twin, this is also a catchy point that if it is a twin, the chances of twin you want to deliver somewhere between 35 to 37 weeks according to different type of twins. So if that is the scenario, definitely it will be 3 to 5 weeks prior, so it becomes 32 to 34 weeks. So please be careful about this. If they give you in question twin pregnancy, then you will choose 32 to 34 in place of 35 to 37 weeks testing. Now, IAP, when you are going to offer, this is the favorite question, and they always want you to know that when you are going to offer IAP and when you will not, right? So, whenever you found she's having a GBS carrier, definitely you are going to offer her IAP. If she has a previous baby with GBS, we already saw we are going to offer, or preterm PPR, we are offer, and pyrexia we will offer. What about if you have detected incidentally earlier in pregnancy? If you have detected incidentally earlier in pregnancy, like if I have done a HUS for a woman at 22 weeks and I found her she's a GBS positive. So I'm not going to treat her that time. I'm going to treat her at the onset of labor, right? No need before onset of labor. So you have to understand that you will give her IAP when she start the labor. This is very important to understand when she will start the labor because it is intrapartum prophylaxis. So when she will start the labor at the onset of labor you are going to give, or if she rupture the membrane you want to give. So before onset of labor or before rupture of membrane, she is not at risk because membranes are intact. Ultimately the infection is in vagina and it has to ascend to the baby. So if there is no labor or if there is no rupture of membrane, the risk to the baby is very less. So no need of giving it if you find it incidentally beforehand. No need of giving it till the onset of labor. So you will give at the onset of labor or at the time of rupture of membrane. Even if you are doing induction, you are going to give because rupture of membrane means the infection can ascend to the baby, so you're worried. So whenever any infection, rupture of membrane is a very critical thing, and whenever you have rupture of membrane, you want to give immediately. So you will give immediately after rupture of membrane and try to deliver her as soon as possible, and at the onset of labor, otherwise you are going to give her the prophylaxis. Now, the specific thing about bacteriuria. If she has GBS bacteriuria, means in the urine you found GBS, just like that, you will offer her only intrapartum prophylaxis. But if she has GBS UTI, means she has urinary tract infection due to GBS, you will treat at that time and then again you will give her IAP. This is also a very favorite question of recall, that when you will give her both or only IAP in cases of GBS bacteriuria and UTI. So please remember this. When you offer her, at what time you offer her, to whom you will offer, and in GBS bacteria and UTI, how it differ. Am I clear about this slide? Because this is really important to understand.
Dr. Shweta, sometimes they're also asking 10 raised to power 5, this one, the serious like this infection in the
Yes,
urine.
if it is 10 to the power 5 means it is infection. If it is less than
Yeah,
10 to the power 5 means it is bacteriuria.
okay. So 10 raised to 5 is important, huh? Like, just I want to confirm.
Yes, if it is
Okay,
10 is to 5 means infection, so you will follow this one. If it is less than
okay.
10 to the power 5, it's bacteriuria, then you will offer only intrapartum. That is the difference about that. Any other doubt you have, that when you will give her the prophylaxis, the time of start of prophylaxis is also important, because you found it at 20 weeks, you are not going to treat her at 20 weeks. You are going to treat her at the onset of labor. Clear, all of you?
You said this was also if the rupture of membranes, then we will give, right? You said like that.
Rupture of membrane you will give immediately, means usually you are giving at onset of labor. In rupture of membrane, she might be not in labor and she has ruptured her membrane, so you will not wait for her spontaneous labor, you will induce her, because this is an infection, you don't want her to delay her delivery. So you will immediately induce and immediately give the IAP. Whenever she rupture her membrane, you don't want to wait even for a minute to start her prophylaxis.
Yes, yes. But the thing is, like some questions which is written like if patient is preterm and rupture of membrane, then they only
Mm.
start this one, erythromycin, and then she go in the active labor. Only then they start giving the prophylaxis like this.
That
It
will
is
depend upon the gestation, which gestation she had rupture of membrane. Because you cannot deliver a PPROM at 30 weeks, because that is more unsafe. Rather than baby having GBS, baby will die of prematurity. So you have to follow the rupture of that, all we will discuss further. It will come in further slide. But whenever you have a rupture of membrane, the delivery plan is according to the week of gestation. So if
okay.
you are
Thank you.
planning to delivery, you will not wait for 24 hours for spontaneous induction, but you will do immediate induction. So if it is indicated delivery, you will do immediate induction. If you are going to do conservative management, then you are not going to give her IAP at that time, because it is ultimately intrapartum. So if you are planning and conservative management, what is the need of giving now? You get
Mm.
my point?
Yes, yes. Okay, thank you.
Okay, dear. Great. So the important points to remember is the not also. What all you are not going to do. So if mother is requesting that I want to do the GBS carrier status, you will refuse, because that is not an indication. The method of induction will be same, sweeping will be same, underwater birth will be same. Don't think that she has GBS, so you cannot induce her, you cannot sweep her, you cannot do water birth. No. No benefit of vaginal cleaning, because that is not going to reduce, so you will not do. PCR or other near patient testing at the onset of labor. Now at 11th hour, no, you are not going to test for GBS. It doesn't make sense. So if you are unaware, if she is at high risk, you will give her prophylaxis in place of testing her. So if she is coming in labor, like in preterm labor, why not test her at that time? No need. They are telling that at the onset of labor, you are not going to test. You will directly offer her prophylaxis. So not recommended to test her at the onset of labor. This is the not slide what all is not going to affect and you are not going to do. So this is about GBS carrier with rupture of membrane, right? So rupture of membrane could be with NVD, could be with plant CS, and could be premature rupture of membrane, right? Premature preterm. So if it is NVD, now here all your doubt of rupture of membrane will get clear. If she is going for NVD, like I got a patient, she's 38 weeks pregnant and now she's in labor. She's not in labor, suppose. Let us take it like spontaneous rupture of membrane before labor. Supposedly she is 2 cm, she came with rupture of membrane. What should I do? I know she's a carrier. She's a GBS carrier. We are talking here about carrier. A woman who is carrier came to me with rupture of membrane but not in labor. What should I do? I will give her IAP and I will do the induction. I will not tell her that we will wait for 24 hours for your spontaneous labor to start, because they say 60% will start spontaneous labor after rupture of membrane, right? So we are not going to wait for that because we want to give her prophylaxis because she ruptured her membrane. She's at risk for GBS for the baby. So you want to deliver her early rather than late. So you will immediately start IUL and you will immediately give her IAP. This is the difference. Otherwise, in NVD, if a woman come to me just like for some other symptoms and I did PV and I found her she's 2 cm, I'm not going to give her prophylaxis because I will give her prophylaxis at the onset of labor. So I will give her prophylaxis when she will come to me with regular contractions, when she's in labor. I'm not going to give. But at the same place, if she come to me at 2 cm without labor but rupture of membrane, I'm going to give her then and there and I will start her induction. This is the difference. Am I clear about this now? About the NVD? That usually you give at onset of labor, but at the rupture of membrane, you will give immediately and start induction rather than waiting for her spontaneous labor. Clear?
Yes, now clear, ma'am.
Great.
Yes, ma'am.
Now, for plant CS, the same way, we are worried for either labor or rupture of membrane because without that, the baby is not at risk. So, if you have planned a CS for some women and she came to you in labor, so you planned the CS, you planned the CS at 39 weeks. Now she came to you at 37 weeks with labor pain. What to do now? Or at 37 weeks, she come to you with rupture of membrane. What to do now? So if she come to you with rupture of membrane, you, as you did here, immediately you started the same way here. She came to you at 37 weeks with rupture of membrane. Rupture of membrane is a risk. You are not going to wait. You will immediately give her IAP. Give her, and as well as you will do the fast track CS, category 2 or 3 CS. So you will take that. This is also important. They will ask you, they will give you an option category 1 CS, 2 CS, 3 CS or category 4 CS. So with rupture of membrane, it will never be category 4 CS. It will never be elective. It will be an emergency. So it will be category 2 or category 3 CS after offering the prophylaxis. So whenever rupture of membrane, immediate prophylaxis is what you want to give with induction itself, with CS itself, or in PPROM if you are going to induce the labor or she is in labor. Both ways. Anyways, in confirmed labor you give, and if induced labor you give. So rupture of membrane, here also rupture of membrane. So same thing. Either labor confirm or induced, you are going to give her. If in plan CS she doesn't have labor or her membranes are intact, she doesn't have rupture of membrane, doesn't have labor, then you don't have to give. So this is important. In plan CS, usually if no labor, no rupture of membrane, no need. But if she come with rupture of membrane, you will give as well as Cat 2, Cat 3 CS. Am I clear about this slide now? Because this is really important to understand, because when you read the question sometime, you will miss the rupture of membrane. You will miss the simple things like if in plan CS and she came in labor or intact membrane, you don't need to give prophylaxis. So this is important. Your risk starts when she goes into labor or she ruptured the membrane. These are the two key points you have to remember. Clear? This slide is clear to all of you?
Yes.
Very good. Now, preterm PPR or intrapartum pyrexia, this I have taken separately because this are something they like about and this is something we get confused about, right? So we all know that in pyrexia the risk is 10 times of transmission and here the risk is 4 times approximately. So 2.3 and 5.3 in place of 0.57 per 1,000. So this is important for us to understand these two situations. If you see in preterm, the mortality is 20 to 30% compared to 2 to 3%. So it is 10 times more mortality. So you are worried about preterm. So if she come with confirmed preterm labor, you are going to give her prophylaxis. We already saw that all preterm we are going to give. We are not going to check them. We are not going to do anything. We are going to give them prophylaxis. So all confirmed preterm you are going to give prophylaxis, but you are not going to give prophylaxis if they are not in labor or if preterm plants cesarean with intact membrane. Definitely, if plants yes intact membrane not in labor, no need. So you will give only in confirmed preterm labor. Now, if you see in pyrexia, they say pyrexia means 38 degree or greater. This is how you do in your clinical practice also. If you get a woman in labor and she develop infection, means she develop fever, you don't wait for her to develop anything. If she develop a fever, you give her broad spectrum antibiotic, which will cover everything, because you don't want her to deliver in fever and transmitting the infection to the baby, or the fever and her condition might deteriorate. So you will start her on broad spectrum antibiotic and you will give her which will cover the GBS also, because pyrexia is a risk for GBS also and you have not tested all the women. So irrespective of testing preterm and pyrexia you are going to give, right? So you will give her broad spectrum which is covering the GBS. So what are they? Either amoxicillin or cefuroxime. Amoxicillin 2 gram 6 hourly means QID, or cefuroxime 1.5 gram 6 hourly QID. So this is important to remember. They will give you a scenario of pyrexia and they will ask you what you will give. So you will choose this or this. If she has PPROM, now here PPROM we are discussing here so that all your doubts will be clear. Testing is not recommended. We already saw anybody with rupture of membrane or preterm or in labor, we are not going to test. So what we will do, if the labor is confirmed or you are going to induce the labor, you will give her IAP. We already saw. Earlier, why this is 34 weeks and not 37 weeks? Because this is according to the old PPROM guideline. Now the new PPROM guideline says that you have to deliver them after 37 weeks. So now it becomes 37 weeks here and 37 weeks here. Because earlier the recommendation was that after rupture of membrane you will deliver at 34 weeks. So that's why they told that after 34 weeks you will expedite the delivery. And before 34 weeks you will do conservative management, because the preterm risk will be more. But now the new PPRM guidelines say that you have to deliver after 37 weeks. So you will expedite the delivery after 37 weeks and then you will give the IAP. And before 37 weeks, you will do the conservative management. And definitely anybody with PPROM, you are going to do the management of PPROM. So you will give them erythromycin. That is a PPROM management. That is different. Anybody, so if I will give you a scenario of this, like if she's at 32 weeks and came with rupture of membrane, then you will choose this one. And you are doing conservative management and she's not in labor and you're not inducing. So you will not choose IAP. You will choose only this one. But if I'll give you at 37 weeks PPROM, you will choose that you will give her IAP also and induce also. So is your doubt clear, Dr. Sadia, now? That how it differs according to if you are doing conservative measures or you are delivering her. If you want to deliver her or she's in labor, you will immediately give. But if you are doing conservative management, anyway, she's not going to deliver for weeks. So you cannot give her IV penicillin for weeks. So you cannot give. This is practically impossible. So you're not giving. So it's a, from practical point of view, if you try to understand, automatically you'll never forget. Because anybody coming in PPROM, you're not delivering her. So how long you are going to give her IV penicillin? So you cannot give. So you will give when she will either come in labor or you are inducing her. Clear now? Because always you want to give her either in labor or with rupture of membrane with induction. Otherwise, you always want to give her when she's in labor. Clear? Okay, great. So now you are clear that when you will choose only erythromycin and when you will choose IAP plus erythromycin in a case of PPRO. So for the time being, you will follow this guideline only, like what they have written, because they will make the question from this guideline only. They will not go to the PPRM guideline till that is updated here. So you will follow less than 34 and more than 34 weeks only for this IAP purposes till they update it in the next guideline. Now, antibiotic, what antibiotic you will give? This is also important. What you will give. So definitely you want to give prophylaxis. They will give you in question that what prophylaxis you will give. Will you give benzyl penicillin? You will give sulfaroxime or amoxicillin or what? So please remember it is benzyl penicillin 3 gram very high dose 3 gram IV followed by half dose 1.5 every 4 hours. So quite frequently. Every 4 hours means 6 times a day. So quite frequent because she's in labor. So maximum 1 day or 1.5 day you will give. So not bad. So 3 gram followed by 1.5 gram 4 hourly. Or even if she induced, if you are inducing a woman, you are expecting the delivery within 2 days maximum. So you can give her 2 days IV, no harm. So now you understood how and why they make the guideline and like when you should give only in confirmed labor or in cases of onset of labor or induction of labor because you want to give her IV. So you don't want to give IV more than 48 hours. So all for all practical purposes, any induced women or with onset of labor will deliver within 48 hours. So 3 gram IV followed by 1.5 gram 4 hourly is what you will give. And first dose you want to give at least 4 hour prior. What is the significance of this? Can anybody tell me? First dose should be 4 hours prior to delivery. Anyone can tell me how the clinical application of this?
Good cover of the antibiotic to the
Baby
baby
will be
protect.
protected.
I couldn't hear you. Can you speak again, my dear?
Baby will get protected if given 4 hours for this antibiotic in the baby also and safe from the.
Yes. So if you give the antibiotic 4 hours prior, the baby will get protection by that one thing, and the other clinical application will be supposedly I have a woman, supposedly I have a multigravida. She is 6 centimeter dilated, suppose, and then I have given her this prophylaxis. So I will not augment her labor. I will wait at least for 4 hours before augmenting her labor because I don't want her to deliver within 4 hours of my prophylaxis. So I'll go slow on her. So that is the clinical benefit that you will go slow on her. You don't want her to give the benzyl penicillin and deliver within 4 hours. So if somebody is progressing fast, you will go slow on her. So that is from your point of view. And definitely, if it is more than 4 hours, the baby will be protected. So you will wait at least for 4 hours for the delivery. Once you have started, you will give it until delivery. That's why I told you all this IV you will give. So that's why you are because you will give it full till delivery. If she has a penicillin allergy, this is also a common question. They will give you an EMQ. In one, they will mention penicillin allergy. One, they will mention she has refused the prophylaxis. So, like that, they make the EMQ. So, if they give you straightforward, you will directly give benzyl penicillin. If they give you penicillin allergy, it will depend upon if she has severe allergy or not. Severe allergy means this anaphylactic reaction means bronchospasm and that all things. Anaphylactic reaction is there. In that case, you will give her directly vancomycin. So your choice will be vancomycin 1 gram BD 12 hourly. But if they give you not severe allergy means only rash, she developed rash with penicillin. So it's not a very severe allergy. So in that case, you can choose cephalosporin. Cephalosporin means ciprofloxacin 1.5 gram followed by half dose, the same 3 gram followed by half dose, the same way 1.5 gram followed by half dose, 8 hourly. The duration also is in place of 4 hourly, 8 hourly. So cephalosporin, why you are choosing for mild allergy? Because 10 to 40% of the cases there is cross sensitivity with penicillin. So that's why if not severe allergy, try cephalosporin. If severe allergy, give vancomycin. This is a favorite question. When to choose benzyl penicillin, when to choose vancomycin. And what to do if women refuses the prophylaxis. Sometimes the prophylaxis is ultimately an antibiotic. It can lead to anything. It can lead to maternal anaphylaxis. It can lead to neonatal altered bowel flora. It can lead to abnormal child development. So these are the adverse effects. So sometimes the women will tell that don't want prophylaxis. In spite of me being carrier, I refuse it. So if she refuses it, you have to respect her wishes and you will not give her prophylaxis. In that cases, what you will do? Can anybody answer me that? She should
Monitor
have
the
received
baby.
and you have. Very good,
Good.
my dear. Very good. So if you have not given her prophylaxis, that means the baby is at risk. So you will monitor the baby because you have no other choice. She has refused. You will not give respect her wishes because she is ultimately the decider. So you will monitor the baby and you will not give her early discharge. Because sometimes in UK they give early discharge, like after normal delivery, if she doesn't want to stay for 24 hours, she can go. Like after cesarean section, even after 24 hours, if she's stable, if she requests, you can discharge. So you will not give early discharge to this woman because you want to monitor the baby. Though the mother has no risk, but baby is risk, so you want to monitor the baby. So that is how your management will differ. Now, what are the important bacteriological consideration? From where you will take the swab? This is also recall question, very important. You will take the swab from lower vagina and anorectum, both the places. Either it could be a single swab from both the area or two different swab could be there, but both the places you have to swab. Why this is important? This is lower vagina and anorectum. While usually in infection like chlamydia, gonorrhea and all that, you take the high vaginal swab, upper vagina. Here it is lower vagina and anorectum. Please don't forget this. Because this is in GI colonization, right? We saw that 20 to 40% of the women has GI colonization. That's why you're taking from anorectum and lower vagina. From there it has come to lower vagina. So that's why you're doing lower vagina, not the upper vagina. Am I clear about this? Because this is really important not to forget this, and this is the simplest thing you can make correct in exam if you understand it well. So swab from these two places, you will collect the swab and then you will transmit it to the particular medium. If you are not able to transport, you will freeze it. So all that things you will consider. Now, how you'll manage the baby? In baby, basically you will look for the sign like any abnormal behavior, feeding difficulty, temperature, all that things, breathing, skin color, all these things will tell you if the baby has developed infection or not. So that all you want to check in the baby. If you think that the baby has all the symptoms or anything which you feel is suspected of infection, then in that case you will treat the baby with penicillin plus gentamicin, because they say that postnatal prophylaxis no benefit to the baby. You will not give prophylaxis, you will wait for the symptom, and if symptoms you will directly treat by penicillin plus genta. So this is treatment. For prophylaxis you give only benzyl penicillin to the mother, but this is treatment for the baby, so you will give penicillin plus genta within an hour. And she can breastfeed, as I told you. Usually in most of the infection breastfeeding is safe except HIV, so breastfeeding will be encouraged. Now, this is how you have to take extra precaution for the baby or not. This you have to understand. If you have done a good thing, if you mother have received the adequate prophylaxis, baby is well, she doesn't require any special observation. So even you can discharge baby early and you're fine. The mother is fine. You both are happy because the mother received adequate IAP. But mother receive IAP with previous baby GBS. This is the only scenario where in spite of giving prophylaxis, you're monitoring the baby. So please don't forget this. Because sometimes they will give you in EMQ IAP plus monitoring of the baby. So you will choose that for previous GBS baby. This is important to understand the difference between these two. Only prophylaxis, well, baby, no need of extra observation, but previous history of GBS, you have to monitor the baby in spite of prophylaxis. And the other scenario, when she refused and she didn't receive prophylaxis, the baby is well, our fortune that the baby is well, then in that case, you will look for the baby, you will observe the baby at least for 12 hours. 0, 1, 2 hour and then 2 hourly until 12 hours, and there will be no early discharge for her. Because here you have not done what is required from you. So that's why you're monitoring. Here you have done what is required from you. Still you are monitoring because previous baby was affected. So double check, double extra precaution because of the previous baby. And here no need of monitoring. So these are the three situations which by which they make an EMQ. Whenever there is 2, 3 situations, similar kind of thing, they will make an EMQ to know how in depth you have understood the guideline, in which situation you need extra observation, in which situation you will do extra observation in spite of a IAP, and usually you will do observation when you don't give IAP when needed. So these are the three conditions you have to remember. Now these are the red flag sign in the baby: respiratory distress after 4 hours of birth, seizures, or if a term baby need ventilation, or sign of shock. So these are the red flag sign in the baby to suspect sepsis of GBS. Now, this is a master chart, and believe me, at the end of it, whatever we have discussed in the guideline, everything is summarized here. And this is really important. Before exam, if you have gone through the guideline well, now you remember everything. Before exam, only once if you see this chart, it's enough to revise everything from this guideline. So please be careful about this chart and try to read it again and again so that you are well versed before exam about this chart, and just a simple look and glance is enough for you. So if you see this chart, this is a pregnant woman, right? So either she will have a planned vaginal delivery or she will have a planned cesarean, right? So vaginal delivery or CS. Now the another important special situation is bacteriuria. We already saw. In bacteriuria, you will offer only IAP, and if she has UTI or GBS, you will offer her treatment that time plus IAP. So this is a special scenario which you already understood. Now, if she has a cesarean section, she is not in labor, membrane intact, no need, because these are the two risk factor for transmission. So if that is not there, no need of IAP. But if she is in labor or membrane rupture, you will give her IAP. So this is about cesarean, this is about bacteriuria. Now, you're planning vaginal delivery, you have to look for all these things, right? So you will look for if the previous baby is GBS, because that is very important for us. So previous baby GBS, anyways, we are going to offer her IAP. If preterm, we are going to offer her IAP for all. So preterm PPROM, you are going to offer her them all. For PPROM, if you are inducing or confirmed labor; in preterm, if confirmed labor. So for all in labor or with rupture of membrane for preterm. Now, if she has the carriage in previous pregnancy, we saw there is two scenario. Either she will choose directly IAP or she will go for testing, and then accordingly you will act. If testing negative, no need, positive, give. So both are possible. Either directly offer or do the testing if previous pregnancy is carriage. Now, in this pregnancy, if she's term, she's in labor, then it depends upon if she has the carriage. If she has a carriage in current pregnancy, you are going to offer her. Any women with carriage, and she goes in labor, you are going to offer. We saw anybody go in labor with GBS or rupture of membrane, we are going to give. So we will give her. Or in pyrexia, like in preterm, we give for all, preterm PPROM, the same way with pyrexia, we give for all, the broader spectrum which cover. So we are going to give. So all these three P's we are anyways going to give. And sometime previous carriage you can directly give. Now, if there is no risk factor, no need. If there is no carriage, nothing. Anyways, for all term baby going in labor, you are not going to give. No risk factor, no pyrexia, no preterm, no carriage, you are not going to give. If pre-labor rupture of membrane, this is SROM. In SROM, again, it will depend upon the carrier status. If she's a carrier, you will do immediate induction and IAP. If she's not a carrier, no need. So in term, always it will depend either she's a carrier with labor or rupture of membrane, you will give, or if she has pyrexia, you will give. Otherwise, in term baby, no need. Term baby with pyrexia, give. Term baby with carriage in labor, give. Term baby with carriage with rupture of membrane, give. Otherwise, no need, right? Because usually in term you don't give, while in preterm you give to all. Am I clear about this chart now? And could you summarize and reflect whatever we have gone through till now? Clear?
Yes, ma'am.
Great. So this is the master chart you all have to memorize well, that when all you offer the IAP. So you offer with previous baby, PPROM in labor. You offer if she has previous pregnancy GBS, you can directly offer. You offer her in cases of bacteriuria or GBS UTI. You offer her if she at term she come with rupture of membrane and known carriage. At term she come in labor and known carriage and pyrexia. So these are the situation where you offer them the prophylaxis. So just to enforce it again, you will give for all previous carriage and invasive GBS and bacteria. You will give for all preterm PPROM. You will give for women at term if she is carriage or pyrexia. So for term, only two indication. This is again and again I'm emphasizing, because in term you please be careful when you give. In term only if carriage or pyrexia. While in preterm PPROM always. In previous invasive, previous carriage, you can, and bacteria always. Am I clear about this? Can I ask you a few questions now? This is the last slide about GBS. Can I go ahead with the questions? You all are clear now?
Yes, ma'am.
Okay, so let me go to the previous slide. Otherwise, all the things you're getting. Okay. Okay, so you tell me that GBS prophylaxis in UK, are they recommending this GBS testing routinely?
No.
No, they are not recommending.
Okay, very good. So if you want to do at what time, usually you will do in a singleton and in a twin pregnancy?
In singleton,
35 to 37 weeks.
35 to 37
No, 32.
Very good. And if it is a twin
in
pregnancy,
singleton and in twin 32 to 34.
32 to
32 to
34 in
34.
twin. Very good. So now
34.
you got a woman with preterm labor, with a suspected preterm labor. Are you going to give her prophylaxis?
no.
No, first
So when you are going to give,
or not.
No,
not established, not
only
established, Dr. Kopa. Be
Confirm
careful. It
preterm.
is confirmed preterm, not established preterm. Established preterm means more than 4 cm regular contraction, not that one. They have mentioned confirmed preterm means you have confirmed the diagnosis after 30 weeks either by scan or FFN. So it confirmed preterm you are going to give to all. Very good. Now I got a woman with preterm pre-rupture membrane pre-rupture of membrane PPROM at 32 weeks. What should I do?
We will give her 250 milligrams.
Only erythromycin. No IAP.
Yes. So you will not give her IAP because you are planning
erythromycin.
conservative management. So in PPROM, when you have to give her prophylaxis?
When she will go to the established labor.
More than 34 weeks.
Yes, more than 34 weeks. So more than 34 weeks, and I'm not planning her to deliver. What should I do?
We'll give her erythromycin 50 milligrams for 10 days.
So when in PPROM you will give? This is why my question. When in PPROM you are going to give her prophylaxis? At what scenario? In PPROM you are going to give her IAP.
According to new
If labor is
guidelines,
confirmed.
give
Either
her
confirmed labor or
Confirmed.
or she is in
Diabetic.
or we
either
are
confirmed
inducing her.
labor or
Inducing
inducing her.
her.
Very good. So either confirmed labor or IOL, I'm going to give her prophylaxis. So any women with ruptured membrane, I'm not going to wait if she is okay. Let me give another scenario. I have got a woman at 38 weeks. She's having GBS bacteriuria and she's 38 weeks and she came to me in with rupture of membrane. She's not in labor. What should I do? 38 weeks with bacteria.
IAP.
Very good. So
Give
you will
AAP
give
and
her
IUL.
immediate IOL because she has carriage as
Induce
well
an
as
IAP.
you will induce immediately. So that is the difference between term and PPRM. In PPRM, you have to decide the delivery accordingly. While in term, any rupture of membrane, immediate IOL and IAP is what you recommend. Now, I got a woman. I have planned for her elective cesarean because she's a twin pregnancy with the first transverse baby. So I planned cesarean for her at 37 weeks. She came to me in labor at 36 weeks. What should I do? I will give her prophylaxis or not?
She is
Give
already
prophylaxis and cesarean
Uh,
section category 1 or category
IAP.
2,
Yes, we will give
category
prophylaxis.
2 or
And
3.
Cat-
cesarean section.
2 and 3.
Category 2 or 3.
Category 2 or 3 cesarean section. Is it for labor or it is for rupture of membrane?
to do the category 1 cesarean, but we also give her antibiotic cover because she is already in labor. And we will give her
Rupture of
Category
membrane.
2 and 3.
1 and Saj, because category 1 anyways is not there because this is not an immediate threat to anybody. So category 1 is out of question. I'm asking if she's in labor, you will do category 2 or 3, or if she's coming with rupture of membrane, you will do category 2 and 3.
In labor.
Uh,
She is already in labor. Transfer.
if
If she comes in labor, category 2
Rupture of
or 3.
membrane.
Yes, if she is with rupture of membrane, She is more at risk, right? So if she is rupture of membrane, you will give her IAP and category 2 or 3 CS. But if she come in labor, you will give her IAP and cesarean. But they have not mentioned for that category 2 or 3. With rupture of membrane, it is more important. So category 2 or 3 they have mentioned. If she come in labor, you will give her IAP and you will do the cesarean. But for that, they have not mentioned it is category 2 or 3. But definitely, at least it will be category 3, not category 2. No need of category 2 for labor, but definitely category 3 because it cannot be elected. So you got my point how it is different with rupture of membrane or without rupture of membrane. With rupture of membrane, even it is becoming category 2, which is within 75 minutes. While if she is in labor, definitely it will be category 3. You got my point? The
Yes.
difference between rupture and non-rupture?
So with rupture of membrane, go for the category
Yes,
2,
ma'am.
labor category
Yes,
3.
better.
Like,
Yes, better.
and we will give
Yes, you
antibiotic
can.
for both of them because she's
Yes,
already in labor
Yes,
and
ma'am.
also
yes, yes. Anytime anybody in labor or rupture of membrane, you want to give them IAP, so you will give them. Okay, great. So all of you remembered things well. Very good.
One more
Uh,
thing, Dr. Shweta. If she
yes,
comes
my
at
dear.
32 weeks and rupture of membranes not in active labor, can't we wait for steroids?
You will wait. For 32 weeks, anyways, you are not planning delivery, my dear. So
No,
less than
but you
34
said
weeks, anyways, you will not give.
category 2 cesarean section, but you will not give steroids that time.
No, steroid is a different story. Steroid, anyways, you will give to anybody who is coming in preterm labor.
Yeah, no, no, I'm just telling when she rupture her membranes not in active labor, and then we
Hmm.
are going category 2 cesarean, there is no time for steroids to act. Yes. When she's not in active labor, can we wait for some time like steroids
Very
to act
difficult.
and
Very difficult for me to comment upon this. From GBS point of view, when they are talking about GBS, you stick to GBS. Then don't go on steroid preterm labor guideline because when they are giving you cesarean section, they are picking the question from here. So they will not talk about steroid. In the option, you will not have steroid and weight. If they want you to choose about IAP and category of cesarean, they will not talk about steroid because then it will become more complicated. That is all more complicated to be discussed by the women, by the consultant. There are many things in obstetric which is not written in the guideline and which they will decide, the consultant will decide after discussing with the women. So let us
okay,
stick to whatever written in this guideline. If they want you to choose, they are making the question with answer in their mind. So they will give you the
okay.
options which will suit to that scenario. If they are making from
Mm,
GBS guideline, they will not talk about steroid. If they are making from preterm guideline, they will talk of steroid. They will not talk of AIP, IAP.
okay,
So don't worry,
okay,
they will not mix and make the question so difficult that you cannot choose answer. If you have
okay.
reached
Not
till
the.
that level of thinking, automatically
Uh,
you are past the exam.
thank you, doctor.
So don't try to create a scenario which is not there in the guideline. That will waste your time because don't keep thinking about what is not written in the guideline. We have to stick to the guideline. We have to remember the guideline rules, and that only come in question, and that only you have to ace in the exam. Clear? Anybody has any other doubt, or we can move forward?
yes,
Okay, great. So I hope now you are very clear about GBS. And once you understand that you have to give in labor or rupture of membrane with IOL, you are almost clear that when you are going to start your IAP.